another lecture. So today's topic would be non-invasive ventilation for nurses. So nowadays, this has become a very popular mode, particularly after the onset of COVID. It has become a very popular mode of giving ventilatory assist to patients who are short of breath or maybe in respiratory failure and for some other reasons. So it is a ventilation without patient interface. Interface is different from the conventional ventilation. In conventional ventilation, what you do is put in an endotracheal tube and then connect the ventilator to that, and then the ventilator starts delivering the whatever the tidal volume, etc. But here, the interface is basically a mask. There are various types of masks which we'll discuss later, but mask which sits on the patient's face and delivers the ventilation through that interface. So NIV basically leads to a reduction in inspiratory muscle work. It supports, gives a pressure support, and it leads to a reduction in inspiratory muscle work and avoidance of respiratory muscle fatigue. NIV also leads to prompt improvement in gas exchange. So the basically what we our motto is that ventilate before intubation. That is, even before the patient can be intubated or needs intubation, even before that we can support the patient. If intubated, extubate early. That is, if the patient is already in ventilation and not requiring much of conventional ventilation, we can extubate and put the patient on a non-invasive ventilation. And if extubated, prevent reintubation. So these are the ideas of using a non-invasive ventilation. What are the indications? Clinical indications are prevention of hypercapnia in COPD exacerbation or treatment of hypercapnia with COPD exacerbation. This is the indication which has been very well studied and proven to be effective. Next, cardiogenic pulmonary edema. That is, the patient has got a left ventricular failure and there is a pulmonary edema. Acute asthma exacerbation. Here it is sometimes used, but we don't have any robust data to support this use of non-invasive ventilation. Immunocompromised patients, where we want to avoid intubation because it might give rise to more infections. De novo respiratory failure. Postoperative patients, that's another indication, that is, you need some amount of ventilator support in a postoperative patient, provided the operation is not in the esophagus or very upper part of the stomach, where it might be slightly contraindicated, relatively contraindicated. Next, palliative care, as I've told you, that the patient is anyway too old, has got a terminal illness, where we do not want to put the patient into invasive ventilation. There we can use non-invasive ventilation. And trauma patients, particularly rib fractures, where they require support. Pandemic viral illness used extensively in last pandemic, but the data to show what happens if I don't use it is not very clear. Post-extubation in high-risk patients, prophylaxis. That the patient has, we know that the patient is a patient of COPD. He got ventilated because of some other reason, maybe because of some big operation or maybe because of a pneumonia. And now the ventilator, we could reduce it somewhat, but not being able to fully wean off the patient when we can actually extubate early and put the patient on a non-invasive ventilation and weaning hypercapnic patients. So what is the indication? When do you actually require this support? We have got the diagnosis indication, but when do you require the support? Patient inclusion criteria. The patient with a respiratory failure who is reasonably cooperative. This is one thing very important, that non-invasive ventilation requires some amount of cooperation. If the patient is very uncooperative, very restless, throwing around his arms and etc., then this is not a patient for non-invasive ventilation, because we don't have that absolute control of an intubated ventilated patient. Then the patient has got a dyspnea, moderate to severe, but short of respiratory failure. Very severe patients, it may not be advisable to put the patient on non-invasive ventilation. Tachypnea, more than 24 breaths per minute. Increased workout breathing, accessory muscle use, parsed lips breathing, and hypercapnic respiratory acidosis, pH in the range of 7.10 to 7.35. If it is even worse than that, then it may not be safe to start a non-invasive ventilation, and the patient may be put onto an invasive ventilation. Hypoxemia, PaO2 FiO2 ratio less than 200. You all know that PaO2 FiO2 more than 300 is normal, but if it's less than that, you can use a non-invasive ventilation. What are the contraindications? There are some absolute contraindications. If the patient has got a respiratory arrest or after an unstable cardiorespiratory status, the patient is in near arrest situation, very ill patient, they should not be put on an NIV trial. Very uncooperative patient, I've already said, you should not use the non-invasive ventilation. If the patient is unable to protect his or her airway, that is cannot cough out well, there is a chance of sputum sticking inside the throat. In that case also, this is not a good machine because it cannot protect the airway, and neither does it allow us any ports so that we can suction, do some suction and take out the the secretions from the airway. Trauma or burn involving the face, as I've told, the mass mostly lies on the face. So therefore, if the patient has got a severe trauma or burn on the face, we don't use a non-invasive ventilation. Facial, esophageal or gastric surgery. These are slightly relative contraindications if the patient has got, because very high pressures in the oral cavity would be transmitted somewhat to the also to the esophagus. And so a patient who has recently got an esophageal surgery may have a blowout of that surgery. There's a theoretical risk. Next, apnea or poor respiratory drive, if the patient is not taking breaths well. That is a relative contraindication in that sense that we have right now got a thing called an ST mode or APCV mode, where there is a backup rate. If the patient does not take enough breaths, the non-invasive ventilation itself keep the backup rate intact. Reduce consciousness, unconscious patient should not be put on NIV. And air leak syndrome, that too much of air is leaking because of the shape of the face, which is not matching that of the mask. That is a problem. Relative contraindications, extreme anxiety, morbid obesity, where again the short neck, etc., might create problem of airway pressure being delivered onto the lung, copious secretions, and the need for continuous or nearly continuous ventilatory assistance. This is another thing. A patient who is requiring absolute non-invasive ventilation support, that he cannot even stay a few minutes off the non-invasive ventilation, is not a good candidate for non-invasive ventilation. Because it is expected in non-invasive ventilation, you'll be disconnecting the mask from time to time to feed the patient or to clear the mouth or clean the face, etc. Next is lack of respiratory drive. If the patient is not taking enough breaths, as I've already discussed, and deterioration. Then you put the patient on NIV, and after some time you see the patient condition actually worsening. The carbon dioxide is going up, patient is becoming more dyspneic. In that case, don't wait, hesitate, put the patient on a tube and ventilation. This is a sort of pie chart which shows the failure of NIV rate. You can see there are three types of failures. One is immediate, one is early, and one is late. Immediate is within less than 1 hour after starting the NIV. Intermediate or immediate, early is basically a few hours, 3-4 hours after the NIV started, and late is after maybe 1-2 days. So you can see the maximum of the patients who fail, they fail early, that is after a few hours after the NIV. So don't be satisfied as soon as you put the patient on NIV and see for 15 minutes the patient is stabilized. Don't let the patient alone. The patient should be very well monitored, because there is a chance of failure in each patient, that which may increase actually from after 1 to 2 hours and go on for another 3-4 hours. That is the time most of the patients, they become fatigued or cannot cough out the secretions and they go into a ventilation. That is first few hours after the NIV initiation in a patient. The patient should be kept under careful watch. Suitable machines for hospital. You can see that basically there are various types of non-invasive ventilation BiPAP machines, we call them. Some are basically very small pocket-sized machines, almost pocket-sized machines with minimal support. So these patients are, and we are talking right now about the NIV in a critical care unit, where the patient is critically ill. That is basically the nurse's domain. So these machines, small machines, are not exactly good for critical care use. So hospitals and critical care, it should have pressure control mode. It should have a high pressure capability. Maybe it should be able to raise the inspiratory pressure to up to 30 centimeters of water, capable of supporting inspiratory flows of at least 60 liters per minute. That is, again, that these patients are short of breath and they got a lot of ventilatory support. Assist control and bilevel pressure support modes, rate capability of at least 40 breaths per minute, sensitive flow triggers, disconnection allowed. These are essential, and desirable is that short pressurized time, adjustable pressurized time, adjustable inspiratory trigger, adjustable expiratory trigger, adjustable inspiratory-expiratory ratio in assist control mode, and temporary alarm cancellation facilities, internal battery with power for at least 1 hour, accessible control panel with cover or lockout facility, simple control knobs, LED and LCD displays. So these are the interfaces. As I've told you, there can be various types of masks in the non-invasive ventilation. The most commonly used is the oronasal mask, which covers the nose as well as the mouth. It can be a pure nasal mask. This is not usually used in the ICUs because the patient's mouth remains open, and often this patient with dyspnea, they breathe from the mouth, where this NIV would be useless. There can be a full face mask. This is slightly better than a nasal-oral mask, oronasal mask, and there might be a helmet-like mask. These masks may be better, but they have induced a rise of a sense of claustrophobia-like thing. The patient might feel that I'm too covered, and if the patient coughs out or vomits, then it becomes a problem to take out the mask and again clean and put them back. Selecting the interface in acute setting, oronasal mask. Outside the hospital HDU, oronasal mask, more likely to have leaks in the acute setting, oronasal mask. Okay, so you can see these are the indications for oronasal mask, and nasal masks are for outside ICU. For nasal CPAP, these nasal masks are good, and helmet mask might be better in the cases patient is having a ventilation, maybe in ARDS, etc. Fitting the mask, you place the mask, oronasal mask on the nasal cavity. It should be fit snugly. There should not be much of leak. It should not be one-sided going up or going down. That should be very careful. And it should be reasonably tight, not too loose. That you can see on your left panel. Basically, you should be able to barely put two fingers inside the band, so that you know this is how tight this is. That is very important. If there is a rise tube, the rise tube should come out from one side of the mask. That is one thing we need to be careful about. And it should not be too tight, as I've told you, that prevents pressure sores. Otherwise, these patients, when they're ventilated for long on a non-invasive ventilation, they develop sores ulcers over their nasal bridge, on their cheeks, etc. Some issues which you may face during non-invasive ventilation are you need to induce nasogastric feeding, because there are many of the patients, they are not so fit to disconnect the NIV for at least half an hour, 40 minutes for feeding. If the patient has very long beard, that might go under the oral mask and or some leakage extra or nasal mask. Excessive secretion, if there is the patient every 2 minutes, the patient starts coughing, producing copious sputum. That is also not good candidate for NIV. Vomiting, and some people have a sense of claustrophobia with this mask, and they resist using these masks. There might be several modes. As I've told you initially, there was only a thing called a spontaneous mode. Most of these machines, that is, whenever the patient takes a breath, the machine gives a support. It could be a flat support during inspiration and expiration, when we call it as a CPAP, continuous positive airway pressure. Or it could be a bi-level, where during the inspiration, the support is more, and during expiration, the support is less. Now, most of the NIVs, they've got an ST mode. Spontaneous, the problem is that if the patient has got less amount of breaths per minute, suppose the patient breathes at a rate of the morbidly obese patient, drowsy patient, obesity, hyperventilation patient, and takes just 5 breaths a minute. The NIV machine does not have any way of basically backing this up. They will only support for this 5 breaths. But now we have got spontaneous and timed mode, that is ST mode, where basically some is spontaneous, where the patient is taking non-breath, and some are timed. If the patient does not take adequate breath, suppose we have said the basic rate to be about 20 breaths per minute, and the patient takes 15 breaths per minute, the NIV will deliver another 5 breaths spontaneously without any patient effort. And now we also have a pressure control mode, which is basically it also not only supports, gives an extra pressure during inspiration, IPAP, but it also decides the amount of time when the IPAP should be given, and there is an inspiratory time. NIV setup, full face mask, or home if use of NIV. Initial pressure settings, you can start with low pressures and slowly increase the pressure. But in ICU patients, when the patient is very acute, sometimes you need to give high pressure instantly. Otherwise, the patient will not tolerate half an hour of low pressure. And slowly the IPAP should be increased if the patient, you find the patient is not taking or tachypneic. And if the patient is hypercapnic, also the IPAP should be increased so long as the hypercapnia is corrected. But if the patient is hypoxemic, then you can increase the oxygen. Afterwards, if not, you can increase the EPAP, which acts as a PEEP as in conventional ventilation and may improve oxygenation. There are also some factors like rise time. Rise time is basically from the start of the inspiration to the time taken to reach the maximum pressure support during inspiration. This is the rise time. The flatter it is, Slowly the air is entering. As sharper it is, more rapidly the air is increasing. If the patient is really short of breath, tachypneic, and you give a very long rise time, what happens is that patient is taking breaths, but they feel that the rise time is going beyond that. They're tachypneic, and in between the expiration, they're causing a dysynchrony. Too short a rise time might also give a problem. So that is what you need to watch. Now, NIV in COPD, as I've told you, this is one of the most important indications. The treatment of choice for COPD hypercapnic failure is NIV. Proven to save lives and shorten ICU stay, suitable only in patients who are conscious or hemodynamically stable. Watch closely for first few hours. We have already discussed this. NIV in cardiopulmonary edema, CPAP is the treatment of choice, but nowadays they say BiPAP is also good. It improves symptoms faster, decreases intubation rate, possibly decreases mortality in subgroups, and indications still fuzzy. Well, we have got indications. There is a cardiogenic pulmonary edema, which is not controllable by drugs and oxygen alone. One can use an NIV. NIV in chest trauma, there was a prospective randomized trial of CPAP given by face mask to spontaneously breathing patients, compared with intermittent positive pressure ventilation with endotracheal intubation. The patient who with flail chest who required mechanical ventilation. Weaning from mechanical ventilation, again you can see there is a generalized favor in favor of the non-invasive ventilation. That is when you feel, as I've told you, in some patients when you're weaning, but we know the patient may fail the weaning because they had a previous COPD, elderly patient, weak patient, where we can plan that we'll intubate and directly go into an NI. So that's a good indication, and it has successfully in many patients. But if the patient has been weaned, kept off NIV for say maybe 1 day, and after that the patient goes into a next respiratory failure, then you should not wait for NIV. You should intubate the patient and ventilate, and again try to get the patient out of ventilation again. So that is the thing. Predictors of failure of NIV for acute respiratory failure. If these things are present, you know that the NIV may not work. Too much of air leaks, Apache score more than 29, that is seriously ill patients, asynchrony, Glasgow Coma score less than 11, lack of compliance or tolerance, pH less than 7.2 persistently, and the respiratory rate 35, the patient is still very tachypneic. Here it is likely to fail. Intubation criteria after NIV failure: if there is a respiratory arrest, loss of consciousness, too much gasping for air, psychomotor agitation requiring sedation, heart rate less than 50, hemodynamic instability with systolic blood pressure less than 70. All these are indications for intubation in a patient who is already on NIV. Minor criteria: respiratory rate greater than 35, pH less than 7.3, and PO2 less than 45 despite oxygen. Increase in is of encephalopathy or decreased level of consciousness. Thank you. That was all you might be facing while handling a patient with an IV. If you've got any questions, you are free to ask me. Deepa, are you here there?
Yes, sir.
So even some chat is there, I can see.
When chat is there, what pressure we should start on CPAP?
CPAP is usually given at 5 centimeter or 10 centimeters of water, depending on the patient's capability or demand, what do you say? Nowadays, we use mostly BiPAP patients rather than CPAP. As I've told you, initiate the BiPAP at the level of 12 by 5 or 12 by 6. And then if the patient does not take enough tidal volume, then you can go on increasing. Many elderly patients or ill patients, they will require IPAP above 20 that you will need.
So one more question is there.
There's another question that in IV bacterial filter apply or not.
Yes.
Basically, you'll have to check out with your, I mean, the machine type of machine. Advanced machines, they allow this HAV filters to be added, but the basic machines, if you use an HAV filter, it may not work. Could you please summarize the whole topic? Well, how do I summarize? Basically, as I've told you that nowadays, previously many patients who had got issues with respiratory failure, they needed to be intubated and ventilated. Now we have got an option that we can avoid the intubation. By avoiding the intubation, we have got some advantages that you don't breach the normal physiological barrier to infection. The patient is not very uncomfortable. The patient can speak. All these things are there is no trauma to the laryngeal structures. So these are the things of advantage of NIV, but disadvantages are that you don't have the control of the airway. You cannot suck out the secretions from the airway. If the patient has got poor cough reflex, then also the patient is not helped. It is not good for very serious patients. So moderately ill patients who require some ventilatory support can be tried on NIV. It has been proven well in patients with hypercapnic respiratory failure, or the patient with a pulmonary edema, cardiogenic pulmonary edema, or the patients who require palliative care or immunocompromised, and you want to avoid intubation. In chest trauma patients with fractured ribs, this is also a good option. So there where you can use. When you use, you can use, basically, I've told you what are the criteria of a good ICU machine that you need to have. The machines which are hardy, can run for 24 hours, have got high pressure IPAP settings possible. You can control the oxygen, uh, given oxygen FiO2. Basically, if there is no blender in the machine, like the old time machines where you give the oxygen by a side port, what happens is that the side port oxygen mixing is depending on the airway flow in the tube. So once you go on increasing the IPAP or EPAP, actually the saturation may fall because the oxygen may mix less from the side port. This is called a Venturi effect. This can be overcome by giving oxygen more than 8 to 10 liters. That is, these are the problems. As I've told you, be careful for the first few hours. Start NIV in a lower setting, maybe 12 by 5 or 15 by 5, and slowly increase as per the demand of the patient. For few years, the patient should be well observed. The signs of NIV failing is that if there is no improvement in blood gas, pH remains less than 7.25 with hypercapnia. If the patient gets drowsy, there is a respiratory arrest, too much of leak, the patient is too restless. What else? And too much of secretion, vomiting. All these are indications that you should, I mean, get out of NIV and put the patient on a invasive ventilation. And signs of NIV failure: if the patient is having a respiratory rate of 30, more than 35, drowsy, accessory muscles working, pH is going lower, in that case, intubate the patient. So that is in short, I've summarized, tried to summarize. Next. Actually, on NIV, sometimes we start on PS, PEEP, along with FiO2, which mode is this. Pressure support by PEEP. FiO2 is basically how much oxygen given. Pressure support by PEEP, that is the usual BiPAP machine. You require pressure support during inspiration, which can be 10, 12, 20, 25, 30. And you've got a PEEP. We don't use the term PEEP here. Here you use EPAP. But possibly what you are telling is these are the normal ventilation machine, invasive ventilation machine, newer, which have got also NIV modes. In that case, the mode should be something like the ventilator, like pressure support, PEEP, etc. terms are used, and you can use them as NIV. I think so. That is the machine we are talking about. On NIV, we set FiO2, PS, PEEP. Which mode is the basically? Basically, PS means it's the IPAP. PEEP is same as the EPAP, and FiO2, that is the oxygen you're giving. This is a ventilator doubling up as an NIV. In newer machines, you can give. That is what it is. You should be using BiPAP mode. CPAP, as I have told you, in heart failure, you can use a CPAP mode too. So what is the difference between CPAP and PEEP? CPAP basically is a flat pressure. It does not vary with inspiration, expiration. There is a flat pressure going on. During inspiration, it acts as a pressure support or a IPAP, where it helps the lung to take some breath. During expiration, it behaves as a PEEP or an EPAP, where it helps in opening up the airways, reducing shunt, and increase oxygenation. So that is the CPAP. But if you are using a bi-level machine, That is, the inspiration and the expiratory pressures are different, not a flat pressure throughout inspiration and expiration. Then the questions of IPAP, EPAP, inspiratory positive airway pressure and expiratory positive airway pressure comes in. If you are using with a ventilator, conventional ventilator, which can be also used in NIV mode, then you'll have terms like PEEP and PS for IPAP and EPAP. Sorry, PEEP for EPAP and PS for IPAP. How to set IPAP and EPAP if applying NIV, because in NIV PEEP and PC above the PEEP setting is there. So as I told you, start with the IPAP of 10, 12 and the EPAP should be around 5 and you slowly increase as per the demand. If the patient is hypercapnic, you go on increasing the IPAP so that the tidal volume increases. If the patient is hypoxemic, you increase the EPAP, but as you don't have any control like a invasive ventilation, what you do is that if you increase EPAP by 3, you'll also have to increase the IPAP by 3. So suppose the patient who has been started on a 15/5 and found having still hypoxemia with 60% oxygen. So I am to increase the EPAP to improve the oxygenation. From 5, I make it 8. In that case, IPAP should be also increased from 15 to 18. So these are the questions I get. Anything else? I guess that's all, Deepa.
Yes, sir. We have no question.
Right. Thank you. Thank you all for finding time to attend this lecture. I'll let you know about the next week's lecture by tomorrow. Thank you.
Thank you, sir.